presentation. This is Samad Hamidi from Iran. He will talk about the situation there. Then you can now, start with your presentation.
Everyone, and thank you all for joining our presentations today, and welcome to the Diversity and Equity in the PCIT Community Conference. My name is Samad Hamidi, and I am a PCIT therapist in Iran, and I am going to talk about the pioneering efforts and cultural challenges of PCIT in Iran. Before I begin, I sincerely thank Dr. Shirai Berg for laying the foundation of PCIT, as well as the dedicated professionals who have supported its growth. A special appreciation to Dr. Cheryl McNeil for her inspiring commitment and invaluable contributions. I would also like to express my gratitude to Dr. Wolfgang Briegel and Asa Gresset Bjurset for all their efforts in organizing this important event. Iranian society differs from Western cultures in areas like gender roles, extended family hierarchy and structure, parent-child interactions, authority and discipline, and communication styles. Gender roles have a significant impact on shaping family dynamics in Iran. While more women pursue higher education and careers, traditional roles remain strong, mothers as primary caregivers and fathers as providers. In Iran, fathers are often the primary decision makers, which means their involvement in PCIT is critical. In fact, in some cases, treatments stop simply because a father disapproved of the mother's participation. Actually, we found that fathers generally showed more resistance to PCIT than mothers. In Iranian society, where patriarchal norms are strong, a therapist's gender appears to influence treatment outcome. For instance, fathers were less at ease being observed in the course of treatment, especially if the therapist was male. Interestingly, on the other hand, mothers seemed more comfortable with a male therapist, suggesting that gender roles in Iran may influence parental acceptance and participation. While extended family have shifted toward a nuclear structure, strong family bonds remain strong. Our research and clinical experience indicated that Iranian parents often face a lot of pressure from extended family members to enforce strict discipline. Many parents in our study mentioned that in social gatherings, especially long holidays like Nowruz, interactions between their children and extended family members can become a source of tension, leading to stress and an increased likelihood of corporal punishment. In such situations, parents may feel pressure to be stricter, and children may even face verbal reprimands or physical punishment from extended family members, conflicting with PCIT goals. Interviews with parents in extended family settings revealed more resistance to PCIT, as they were influenced by traditional family views which opposed techniques like follow the child's lead. Iranian parents, as well as family members, have a strong tendency to instill respect in children, which often leads them to focus on instructing children in correct behavior. Therefore, Iranian children often receive a lot of commands or guidance not only from their parents but also from their extended family members, which pose a challenge for PCIT implementation in Iran. For example, when a parent asks their child to hand over a teddy bear, the child complied. The parent responded, "Thank you, but it's better to say here you go when you give the teddy bear." When implementing PCIT in Iran, we had to consider cultural differences in parent-child interactions. While coding these interactions based on the depicts, we found that some parent responses in the playroom, which might be seen as controlling in Western cultures, are often viewed as a sign of care and concern in Iranian culture. For example, in the playroom, when a father chooses activities for the child, corrects the child's mistakes, guides or directs the child's behavior, these actions are typically interpreted as expressions of care, responsibility, and active involvement in Iranian culture, rather than being perceived as controlling or restrictive. In the playroom, we observed that Iranian parents take a more authoritative approach to managing their child's behavior. This reflects their strong tendency to guide and direct the child's actions, showing a weaker inclination to follow the child's lead. They also limit the expression of emotions in their children, and feel that both positive and negative emotions should be controlled. This tendency stems from concerns about social judgment and the fear of losing control over their children's behavior. For instance, one mother shared her hesitation to allow her 4-year-old son to lead in the CDA phase, expressing, "If I let my son take the lead in the playroom, I'm certain things will get out of control. I don't know what could happen. His behavior might become uncontrollable and leading to embarrassment for me." Through qualitative interviews, we learned that Iranian parents feel embarrassed about expressing their emotions and prefer emotional restraint, viewing it as a sign of self-care and maturity. This presents a significant challenge for implementation of PCIT in Iran, as parents in our study needed more time to feel comfortable expressing their emotions freely throughout interactions with their children in the playroom. Understanding the cultural expectations of Iranian regarding authority and discipline is essential. It is important to be sensitive, especially when cultural beliefs about disciplines such as corporal punishment conflict with PCAT principle. These beliefs are rooted in various ethnic backgrounds and Islamic teachings in Iran, complicated parent-child interactions, and pose additional challenges for PCAT therapists. In our research, we found that families with lower levels of education were more open to direct coaching and prefer clear guidance on what to do and what not to do. On the other hand, parents with higher education and more critical thinking sometimes criticized the more structured nature of coaching and initially feeling that it placed too much control on them. It is also essential to understand Iranian communication styles. Edward Hall's distinction between high context and low context culture is important here. Iran is a high context culture where communication relies more on symbols, nonverbal cues, and context. In these cultures, language can be vague and meaning is often conveyed through nonverbal signals. In contrast, in low context cultures like those in North America, where PCT was originally developed, a focus on direct and clear communication. In Iran, communication tends to be intentionally ambiguous, with a strong reliance on nonverbal cues to decode messages. This linguistic and cultural nuance present challenges for PCAT, as PCAT therapists must carefully consider context to accurately interpret messages. When coding Iranian parent-child interactions based on the depicts, we found it difficult to capture the nuances of these nonverbal cues, leading to discrepancies between SSS. For example, humor in the Iranian culture can be complex, and distinguishing between parental humor and negative talk was often a challenge, leading to a lower interrater reliability. Since conveying meaning in Persian and Kurdish require more context and effort, parents tended to over-explain their child's speech when they are reflecting their child's speech, missing opportunities to practice reflecting future verbalizations. Similarly, therapists had to balance providing clear feedback while being concise. Therefore, to improve reflection, parents were reminded this was a turn-taking game, and at times they need to remain silent to give their child space to speak. Direct feedback was sometimes necessary to encourage parents to lower their voice or stay silent. In this slide, you can see the steps taken to advance PCIT in Iran. First, in addition to obtaining PCIT certification, we translated PCIT treatment protocol, the DPS coding system, and other necessary assessment materials into Persian. Then we standardized the DPX to pave the way for the dissemination of PCIT in Iran. Next, we conduct semi-structured interviews, focus group discussions, and observations of parent-child interactions on natural settings based on the depicts. And through content analysis, we identified the key cultural elements for adaptations. Based on these insights, we designed and implemented interventions that consider these cultural adaptations to assess accessibility and effectiveness. Afterward, we refined materials based on feedback from parents through qualitative interview. Finally, we designed a controlled clinical trial considering differences between fathers and mothers to evaluate the effectiveness of PCAT approach. And the results were remarkable. Currently, we are training therapists, creating educational content to introduce this valuable approach on social media and organizing training workshops for colleagues to expand PCAT in Iran. Barriers to dissemination and implementation of PCIT in Iran. Authoritarian parenting, resistance to follow the child's lead, and negative perceptions from extended family members can create a challenge for implementation of PCIT in Iran. The shortage of trained therapists and the unavailability of PCIT materials in Persian hinder the widespread implementation of PCIT in Iran. The high cost of therapy room equipment, including cameras, one-way mirrors, and audiovisual tools, create challenges in setting up and maintaining PCIT program. Corporal punishment of children is both legally and culturally accepted in Iran. Physical discipline is regarded as a normal part of parenting. As I mentioned, one of the most important factors that challenge implementing PCIT in Iran. Iranian parents often delay or avoid completing daily homework. Economic and political instability in Iran leads to high parental stress for implementation of PCIT in Iran. PCIT is not properly introduced in Iran due to a lack of certified therapists, causing misconceptions and deviations. To date, about 35 studies mention PCIT, but none follow the standard protocol and the DPICS manual. Many describe unrelated interventions. I am the only PCIT therapist. As a result, our research was the first in the country conducted by a certified therapist using DPICS and the treatment protocol. This graph illustrates the progression of two skills among Iranian parents throughout treatment. At the beginning, all three behaviors, labeled praise, reflection, and behavioral descriptions, were used infrequently. However, as the sessions progressed, these skills showed a steady upward trend, more consistent increase in the CDA phase, and some fluctuations in the PDA phase. Interestingly, continuing therapy beyond goal criteria led to even better outcomes. Following results show that although some declines was observed, many improvements remain. Parents often worry that those skills, particularly labeled praise, might spoil their children, reduce intrinsic motivation, or foster dependence on external validation. Many prefer using unlabeled praise and thinking it encourages adaptive behavior. Cultural beliefs like the evil eye also make parents hesitant to praise their children, especially in social settings. Some parents worry that praising positive opposite, which might distract from correcting negative behavior. At baseline, reflection was one of the least frequently used skills. After training, parents tended to use reflection in combination with subtle constructive guidance. For example, if a child expressed fear of the dark, the father might reflect, "You're afraid of the dark, but the darkness has no fear. You must be strong." A major challenge was that when parents attempted to describe a behavior, often they immediately followed it with a command or a question. For example, if a child was drawing a snowman, the parent may say, "I see you drawing a snowman with details. Don't forget the hat. Let's do it together." Or similarly, when building a tower, a parent may describe the behavior and add, "I see you're stacking the blocks. Let me show you how to do it correctly." This graph shows the decrease of don't skills among Iranian parents over the course of treatment. Initially, all three behaviors were high, with questions being the most frequent, followed by commands and negative talk. Over the course of treatment, all behaviors significantly decreased, reaching their lowest level around session 11. After that, there was a slight increase in all behaviors, especially questions, which remained higher than others. This pattern, observed in both clinical practice and research, suggests that many parents struggle to coordinate their CDA skills with the demands of the PDA phase. Iranian parents tend to ask more questions, which challenges CDA criteria and appears to be a natural part of Iranian parent-child interactions. This tendency is influenced by both the ambiguity of the language and the high context nature of the culture. In Iranian culture, criticism is often viewed as a necessary part of parenting. Many parents use criticism to guide and correct their children, believing that children are unaware of their mistakes and need criticism to learn. These charts show changes in the ECP intensity and problem scores the course of treatment. Initial high scores indicated significant disruptive behavior reported by parents. However, scores showed a clear decline as sessions progress. An interesting observations when the PDA phase commences. At this transition point, there is a slight increase in scores, indicating a temporary rise in disruptive behaviors. However, after this brief challenge period, scores start to decrease again. This graph shows the number of sessions Iranian parents need to complete the CDI, PDI, and overall PCIT. For CDI, the number of sessions range from 7 to 12 with an average of 10, indicated that Iranian parents needed more time to reach the goal criteria due to not following the child's lead. Fathers also
Dr. Hamid, you have 2 minutes left of your presentation.
Fathers also need more time to reach the goal criteria than mothers. In PDI, the session range from 8 to 12 with an average of 10, and overall PCIT 15 to 22 with an average of 10. Another challenge is that Iranian parents have a low homework completion rate. At the mid-treatment assessment, only 43% complete their homework completion, and after the treatment, this completion rate increased to 57% by introducing daily phone reminders and introducing and emphasizing the importance of homework completion to session progression and providing video examples for parents. This chart shows the perceived support among Iranian fathers and mothers during CDA. Mothers reported less frequently than fathers. In this slide, you can see the parenting stress over the course of treatment among Iranian parents. At the start of treatment, mothers had higher stress than fathers. After the treatment, both fathers and mothers showed reduction in stress, but at the 4 months follow-up, the mother's stress remains stable, but the father's stress decreased. This slide shows that 49 parents, Iranian parents, report no or poor acceptance by their community, and by the end of treatment, 28% reported feeling partial or high acceptance. 57% becomes a neutral towards a PCIT. This graph shows the parenting practices across the PCIT. As you can see in this graph, PCIT strengthens positive parenting and reduces inconsistent and punitive parenting in course of treatment, and after the treatment, results were remained. In this slide, you can see in a controlled clinical trial, we assess the effectiveness of PCIT improving positive parenting in fathers, mothers, and a control group. Mothers, as at the pre-treatment assessment, had higher levels of positive parenting than fathers, and after treatment, both fathers and mothers showed progression. However, after the 4 months follow-up, mothers decreased their positive parenting scores compared to fathers. In this slide, you can see inconsistent parenting in cross-treatment. At the beginning, as you can see, mothers showed higher levels of inconsistent parenting, but fathers and mothers after treatment showed improvement. At the 4 months follow-up, mothers showed inconsistent parenting scores more than fathers. This graph highlights the widespread use of corporal punishment in Iranian parents and family members. The effectiveness PCIT to reduce punitive parenting in PCIT. As you can see, mothers at the start of treatment had higher punitive parenting strategy than fathers. PCIT can be highly effective for addressing behavioral issues in children, and Iranian parents needed more time and efforts to fully engage with the PCIT program. Thank you all for your time and attention. I hope this information shared today was helpful. I'm more than happy to take any questions now, or feel free to reach out to me at samadhamidi@gmail.com.
Thank you, Dr. Hamidi. We have a couple of minutes for questions, if anyone wants to.